Hello again. Okay, so this is the beginning of Genitourinary. 2 chapters in your Med-Surg textbook. We're going to start with the first chapter, which is on urinary system function, assessment, and therapeutic measures. And so it starts off with basically a review of the anatomy and physiology of the genitourinary system. And we have 2 kidneys, which are located at the flank area bilaterally. And from each kidney, there is a ureter. The ureters both connect to the patient's urinary bladder, which is nothing more than kind of a holding tank for urine. And then the urinary bladder, the urethra, which is the exit route for urine to exit the body. I'm not going to go through the anatomy of the interior of the kidney. You certainly can review that on your own. Understand that the nephrons are the smallest functioning unit of the kidney. And when we go back and talk about things like diuretics, for example, loop diuretics, furosemide, and bumetanide, Lasix and Bumex, they really kind of kick the kidneys in the nephrons at the loop of Henle, which is, why they're called loop diuretics, to kind of get the kidneys to go into overdrive to pull fluid from the body when the patient's retaining fluid. When I ask students, what do the kidneys do? I usually get, they filter. They're filters. And that's true. But you really need to know that the kidneys are responsible for the formation of urine. And urine is waste. It is toxic waste that is in the body from various areas that is filtered through the blood. The kidneys filter it from the blood, make urine, and then you excrete the waste, okay? The kidneys are responsible for managing your blood pressure, and they do that by managing how much fluid you hang on to and how much fluid you get rid of. So in other words, think about that person with the really big legs that are swollen, loaded with edema. How hard does the heart have to work to pump blood to get past all that fluid? Well, that is going to increase their blood pressure because the heart has to work harder to pump the blood. There's peripheral resistance. When we increase peripheral resistance, we increase blood pressure. So the kidneys, by managing fluid, how much do we keep, how much do we get rid of, thereby in turn manage blood pressure. Kidneys manage electrolytes. They are critical. Potassium, magnesium, calcium, sodium, right? Phosphorus as well. These are all electrolytes. And remember the key elements when we talk about these electrolytes. When you think potassium, you think muscle. When you think calcium and magnesium, you think nerves, okay? The other thing the kidneys do, the kidneys are BFF with the lungs, and they manage acid-base balance. So the kidneys are in charge of the alkaline, which is the bicarbonate. When you look at ABGs, you see that the ABGs contain the HCO3 negative, that's the bicarbonate. Kidneys are in charge of that. That's the alkaline. Lungs are in charge of carbon dioxide, CO2, and that is the acid. And so they work together constantly to make sure that the pH of your serum, your blood, is always 7.35 to 7.45. So one of the things that you're definitely going to need to know that we're going to go over are your ABGs. Know the numbers and understand alkalosis, acidosis, and compensatory mechanisms. Your kidneys are also in charge of activating vitamin D. And why is vitamin D important? Well, calcium really needs vitamin D to help it be absorbed, readily absorbed. And vitamin D is activated by the kidneys when you get some sunlight, right? And so the average person really only needs 15 minutes of sunlight 3 days a week. More than that's even better, but that's the minimum amount that you would need. The kidneys are responsible for producing a hormone that's called erythropoietin. And erythropoietin is necessary for your bone marrow to make red blood cells or erythrocytes. People that are in renal failure, they're anemic. Think about it. Because if the kidneys have failed and they're not functioning, then the kidneys can't make erythropoietin. If the kidneys can't make erythropoietin, your bone marrow is not going to be able to make red blood cells, and you are going to be anemic. Production of renin. So there's this system that happens in the kidneys. It's the renin, angiotensin 1, angiotensin 2, aldosterone, antidiuretic hormone. And the system in the kidneys is constantly working, and it manages how much fluid you hold on to and how much fluid you get rid of. Again, back to managing your blood pressure. I'm going to go into a more detailed lecture about that a little bit later on. Okay, so those are like the basic functions of the kidney. We're not going to get into glomerular filtration rate. Say that 3 times fast. But I want to make sure that you know the ureters are basically the tubes that go from the kidneys to the urinary bladder, and the urinary bladder is just a storage facility for urine. And then the urethra is that exit route from the urinary bladder out to allow the urine to leave the body. When we talk about what is, I hate the word normal, but we do have to say within normal limits. What should urine look like? Well, the average person, healthy, average adult, puts out about 1,000 to 2,000 milliliters of urine in about a 24-hour period. Urine should always have color to it. It should be anywhere from a pale yellow to an amber. If urine is colorless, so it's got no color at all, it looks like water, that's not good. If urine is dark, if it looks like, say, this bottle of Snapple, right? That's very bad also. Urine should have some color to it. But the clarity should be clear. Don't confuse color and clarity. So the color of the urine, yellow to amber, clarity. There shouldn't be anything floating in the urine, no sediment, no particles. And then here's something else that you really need to know, specific gravity. The specific gravity of urine, 1.005 to 1.030. It talks about the concentration of the urine. So specific gravity of urine is the equivalent of what hematocrit is to your blood. It talks about, is it dilute or is it concentrated and thick? The lower the number, the more dilute the urine is. The higher the number, the more concentrated the urine is. You definitely need to know that. pH of urine. Urine's more acidic, right? 4.5 to say 8.0, but the average is somewhere around 4.5 to say 6. And what's it made of? What's in urine? Well, it's mostly water, believe it or not. But the waste products that are in your urine are urea, creatinine, uric acid. So think about it. When we do blood work to look at kidney function, 2 of the main labs that we're doing are BUN, blood, urea, nitrogen, urea, and the other one is creatinine, okay? So these are waste products that your body's supposed to be excreting. Your kidneys are supposed to pull them out of your blood and put them in your urine so that you can pee them out. If your kidneys aren't working properly, then they can't filter properly. And so the urea, the creatinine spills back into the patient's bloodstream, causing the BUN and creatinine to be elevated, okay? And uric acid is one of the main causes of gout, which we will talk about later on too. When we look at a urine analysis, there's some important things to keep in mind. Urine should never have protein in it. Never. If there is protein in the urine, which is proteinuria, that is a bad sign. That means that the kidneys, for some reason, are taking a beating. High blood pressure for an extended period of time can cause proteinuria. There should never be ketones in the urine. Ketones are an acidic byproduct of the body cells burning fat for energy, like in diabetic ketoacidosis. If there are ketones in the urine, then patient's going into ketonuria, which is a sign of diabetic ketoacidosis. And glucose, there should not be glucose in a patient's urine. Again, sign of high blood sugar. Make sure you take a look at the chart, the flow chart about aging in the urinary system. A lot of things happen as we get older. They happen to other people, not me. But renal function starts to decline a little bit. The muscles of the bladder can start to become weak, which is one of the reasons why we see incontinence for, in some older people. But, there are things that can be done to ward that off or prevent that from happening. And then the other thing, too, is that reflex, the voiding reflex. It is the signal that the bladder sends to the brain that says, hey, hello, the bladder's full. time to go pee, that starts to get slowed down or delayed a little bit with aging as well. If a patient has renal disease, understand you cannot live without your kidneys, right? You can live with one, but you cannot live without your kidneys. You have to have at least one functioning kidney. And when we start talking about things like chronic kidney disease, CKD, which is also known as renal failure, it's in stages. So CKD, chronic kidney disease, goes from stage 1 to stage 5. Stage 5 means total renal failure, kidneys stopped working, and basically it's a dialysis patient. So the patient has choices. They can either be dialyzed, go to dialysis, or they can get on hospice because they'll die. Or if they are a candidate for a kidney transplant, that's another option, but that's hairy, and we'll talk more about that later on. When you're assessing a patient, you want to ask them questions about their health history, if they have pain in the flank area, if it burns when they void, if they have any edema, shortness of breath, sudden weight gain, always a sign of fluid retention. And find out how much are they drinking in an average day, and what is their functional ability? What are they up and moving around? You check vital signs, lung sounds, and edema, because these are all signs of things. Crackles, we know pulmonary edema, that's fluid overload. I told you this in term 3, but you might not remember it. We're talking about managing fluid balance. The best way, really the only way, to assess fluid balance in a patient is to do daily weights. Not every other day, not once a week. You weigh the patient. The patient must be weighed every day, same time, after they wake up, after they pee, before they eat. Same scale, same location, same amount of clothing. And that is considered their real weight, because they may get weighed at their house and then go to the doctor's office later, and the weight could be totally different. The weight at the doctor's office doesn't count. It's the weight that we're getting from their home scale every day. So remember, daily weights are the only best indicator for fluid balance. And of course, we can do I&Os to see, what's going in, what's coming out. And then you want to look at a patient. You can get a lot of information just by observing a patient before you even start to talk to them. If they look yellow, or they have a gray look to them, or if they look like they've been out in a snowstorm and they're covered with this frost that's called uremic frost. Google image it, it's pretty cool. That means they're going into renal failure, because the kidneys, instead of processing the waste spills into the blood. And then, of course, the blood is everywhere. And so the waste spills through to the skin, and the skin develops this frost. It's called uremic frost. If you're getting a urine analysis, it's always better to get the first morning specimen. You need to get it to the lab within an hour, or it needs to be put in the fridge. Make sure you know that. And then there's a 24-hour urine. Usually that is an endocrinologist ordering that. So the patient has to void and discard the first urine and then record the time. So let's say 0900, we're starting. And then every single time they urinate, the urine must be put into this jug. It's a big orange-looking jug. And it needs to be every urine. If they miss or forget one time, the whole test is void, and they have to start all over again. It has to be accurate, because they're looking for very specific information with a 24-hour urine. And then, of course, we have a urine analysis, urine culture, and sensitivity. If we suspect a bacterial infection, we're going to order a CNS, culture and sensitivity. And culture and sensitivity. Culture determines what kind of presence of bacteria there, what are they. And then the sensitivity tells us what antibiotic will work for that particular strain of bacteria. Okay, and that's important to know. For labs, you must know serum creatinine, BUN. Don't worry about these others. I'm highlighting in this PowerPoint those two. BUN normal is 10 to 20, and serum creatinine is usually 0.2 to, say, 1.2, somewhere in the ballpark. I'll even call it 0.4 to 1.2. Okay, so make sure you know those labs. They're highlighted. Whenever a patient goes for any kind of a angiogram or CT scan with contrast dye Contrast dye is considered nephrotoxic. And there are lots of drugs out there that are nephrotoxic also, but contrast dye must be allowed to excrete from the kidneys. If the patient's got an elevated BUN and creatinine, we may not want them to have contrast dye because their kidneys might not be able to excrete it. One of the biggest issues with renal problems, type 2 diabetes. That is actually the #1 reason that people are on dialysis. Yes. And it's totally preventable, which is sad. If we suspect renal cancer, then a biopsy would be done. But, you know, that's a whole nother story. We'll talk about cancer when we get into the actual chapter that's just dedicated to cancer. Okay. KUB, which is a radiological study, kidneys, ureter, bladder, X-ray, can see some things. It can see things like tumors, lesions, can see if the kidneys are enlarged or swollen, can see if there are stones in the kidneys. Can't really see things, you know, more specific or at a smaller, more detailed level. You need CT scan or MRI to get those more specific kinds of studies. There's IVP, which is an intravenous pyelogram, and that's looking at the renal pelvis. The renal pelvis is the bottom of the kidney that actually becomes the ureter, okay? And it's important to know this now. Why? As the kidneys are making urine, the renal pelvis can only hold somewhere about 15 milliliters of urine, which is not much, okay? Let's say the patient has a kidney stone that is actually jammed in their ureter. Well, the kidney's still making urine, and that 15 mils has now gone down through the ureter, is trying to pass the stone, but it can't. That urine is going to back up into the kidney, and it's going to be a problem very shortly. So that's why that's important to know. Just know what an IVP is on this page. Don't worry about retrograde and antegrade. You don't need to know all that. Make sure you check patients' allergies before they have the test, and always, always BUN and creatinine. And fun fact, when we're talking about real renal damage, excuse me, BUN, if that's elevated, just the BUN is elevated, that can just be a sign of dehydration, okay? The creatinine is the more, I don't want to say more important, but more definitively diagnostically. So to tell us that, hey, there's a problem with the kidney that's beyond just a simple dehydration. So make sure you remember that little tidbit. There's an example of a pyelogram. Renal angiography is an angiogram, which is contrast dye, looking at the blood vessels that are in the kidney system. Cystoscopy, remember, whenever you hear oscopy, it's a scope. That cystoscope is a scope that goes into the bladder. When we talk about medical terminology, remember, the bladder, that if you have a bladder infection, it is cystitis. That's the medical term. So cystoscopy is a scope into the bladder. Goes through the urethra. Not fun. We can do ultrasounds. We can do biopsies. There's some nursing diagnoses here. Different types of incontinence, which I'm going to talk about a little bit more in depth because ATI likes to talk about that. And then urinary retention. Urinary retention can happen for lots of reasons. Let's talk about that real quickly now. Anesthesia and just opioids in general, can cause urinary retention. And I'm going to add opioids here too. Medications, other medications, anticholinergics can cause urinary retention. And then, of course, trauma, if the patient's in some kind of like a motor vehicle accident or something, that can do it. Chronically, medications, of course, but the biggest issue with men as they age is the prostate gland, which is a gland that kind of sits underneath the urethra. The urethra, the prostate cradles the urethra. I'm going to get a picture and put it up in this PowerPoint so you can visualize it. But the prostate will enlarge. If the prostate starts to enlarge, it's putting pressure on the urethra. That makes it difficult for a man to initiate the flow of urine, keep a steady stream. Men will complain, I try to go to the bathroom and it's like drip, drip, drip. So prostate problems with older men, which is called benign, meaning harmless, prostatic of the prostate, hyperplasia or hypertrophy, enlargement, okay? Very, very common among older men. If somebody has urinary retention, of course, you're always going to monitor their urine output, check for bladder distension, and a lot of facilities love those bladder scan devices. They're all right, but the only accurate and foolproof way to tell if somebody's retaining urine is to do a residual, residual urine volume. And what that means is you have the patient void, and then you do a straight cath. And you see how much urine was still left in the bladder after the patient voided. If there's anything greater than, say, 100, 150, they have a problem. Okay, that means they need some type of treatment. They have urinary retention. Urinary catheters, Foley catheters, indwelling catheters, we can only put them in for a justifiable reason. If a patient's incontinent, it doesn't warrant a catheter, because a urinary catheter, an indwelling catheter that's in all the time, is a 24/7 open highway right into that patient's bladder, and the risk for infection is crazy high. Intermittent catheterization, and we'll talk about some of the reasons why that would need to be done, say for a patient that is a quadriplegic. It's actually a lower risk than a Foley catheter. So here's another evidence-based practice story. For years, the medical community thought, we don't want to keep putting a catheter in and taking it out, and putting it in and taking it out, meaning intermittent catheterization, because every time we're doing that, there's a risk for infection. Put a Foley in and leave it. We were wrong. So now we know that the Foley is actually the higher risk. So intermittent urinary catheterization is a lower risk for infection than an indwelling urinary catheter. Make sure you know that. Remember, if let's say the doctor orders a UA with CNS, urine analysis with culture and sensitivity. Typically what the doctor will do is, if we suspect the patient has a UTI, urinary tract infection, cystitis, bladder infection, the doctor's going to order a urine analysis with a CNS, culture and sensitivity, and he may start the patient on empirical treatment. In other words, a broad spectrum antibiotic, because the culture and sensitivity takes 48 to 72 hours to get back. So we don't want to wait to treat 78-year-old grandma for her UTI a whole 2 or 3 days. So we'll start her on a broad spectrum antibiotic. So you must always get the UA CNS first, then start the antibiotic. Then when the results come back 48 to 72 hours, at that point, we'll look at it and say, okay, well, let's stop that broad spectrum and we'll start her on a more narrow, specific drug for that bacteria. Fun fact, older women, #1 bacteria causing cystitis, Escherichia coli, E. coli. Why? Well, E. coli is a bacteria that's normally found in the GI tract, particularly in the intestines, but numbers of it are kept in check. So older ladies, arthritis, pain, if they have issues of forgetfulness or dementia, and they don't wipe correctly, if they wipe from back to front, they are literally taking the E. coli from the feces and putting it right at the doorstep of the urethra. And the bacteria are like, cool, there's a new home to go to. Let's go in here and see what's going on. So that's the #1 cause. And then the other reason for it is incontinence. So, you can't leave anybody in a soiled diaper. It's not right. You wouldn't want it done to you. That is just asking for an infection. It's asking for skin breakdown, which can lead to infection. And it's abuse. It's abuse. There's no other way to say it. So they're the reasons for urinary tract infections, and E. coli is usually the bad guy that's causing it. The rest of this PowerPoint goes through some review questions, so you can definitely take a look at those. And I'm going to say ta-ta for now. This is part 1, and there will be more to come. All right. Peace.